It's very interesting if we take a historical perspective of liver cancer. Before sorafenib in 2007, systemic drugs didn't have activity. By default, doxorubicin took on this first-line treatment, but there was no data to justify that. And so I think interventional radiology expanded to fill a void, right, in that studies did show in selected patients that chemoembolization improves outcome in selected groups. And in practice, that's been applied, I think, a little more broadly, right? And the question becomes, now that we have more drugs available for liver cancer, how do we triage patients for chemoembolization versus systemic treatment? And you touched on it in the context of the Barcelona criteria, which you and I are very familiar with. And to the points we've talked about before, unlike other cancers where tumor known metastases, the TNM system has good prognostication. It ignores the competing risk of liver dysfunction, whereas Barcelona kind of includes that, as represented by Child-Pugh score. So let's just walk through a typical scenario. I think a patient comes in, they've had known hepatitis for a long time, maybe haven't been screened so adequately. It could be Hep B or Hep C for that matter. They start having, some abdominal pain. They come into the clinic and they're evaluated and they have, a tumor in both sides of the liver, but no invasion into the vasculature, no extrahepatic spread. I think a lot of us would say this is an intermediate patient, probably beyond transplant or curability, and therefore they get chemoembolization. How do you follow these patients? Or, you alluded to the fact that these patients will eventually progress to advanced disease, right? Because we don't cure them with chemoembolization. And, when do we make that switch?
Yeah. So the trigger for switching from loco-regional TACE to systemic therapy is a bit tricky because there are not necessarily standardized or agreed upon criteria. I think in Japan, they follow certain criteria which are probably the most used in a systematic fashion, at least in Japan, and reported on. But generally, there is agreement that if patient doesn't achieve a good response, meaning either a complete response or a very solid partial response in the treated lesion, after 2 TACEs, then this is a patient who's not going to benefit significantly from additional TACE.
Even though they don't have disease outside the liver, right?
Even if they don't have disease outside the liver. So a patient like this who hasn't achieved a deeper response or who's actually just had stability of disease after 2 TACEs, I think these are patients that would be very fair to switch to systemic therapy, especially now that we have multiple options available, so we can maximize their exposure to sequential therapy and hopefully have the biggest impact on their survival. The other concern that you may be alluding to in your question is that loco-regional therapy can take a toll on liver function. Right, so additional TACEs can compromise liver function, which then prevents the access to maybe systemic therapy.
Sure, especially if, as we'll talk later, about second-line, third-line options. And when we're talking about systemic treatment, the new player on the block, right, has been lenvatinib. The REFLECT study was a non-inferiority study that took patients with advanced liver cancer, so patients who had progressed on TACE, either with, as you described, they didn't have good TACE control, or they had extrahepatic disease, or even vascular invasion within the liver. Patients who had main portal vein invasion in this study were excluded. And it met its endpoint of non-inferiority. It had some improvement on secondary endpoints, response, PFS, TTP. But now you have a drug that you've been working with for a decade, and now a drug that's relatively new. So this patient of yours who was getting a chemoembolization now has vascular invasion in the liver. What's your decision process?
So as you alluded to, vascular invasion or the development of extrahepatic metastases is a reason to switch to systemic therapy. So your question now, we have 2 first-line options. We have sorafenib, which we've used for a long time, and lenvatinib, which is a newcomer based on a non-inferiority study. So I consider these as 2 options for patients. In this non-inferiority trial, the overall survival was comparable between the 2. So in theory, physicians can choose either one based on preference. If we look at adverse event profiles, side effect profile, they tend to overlap quite a bit with a couple distinctions that we see higher frequency of hypertension with lenvatinib and higher frequency of hand-foot skin reaction with sorafenib. So these are things that one could take into account when choosing. As far as the
For
secondary...
example, like a patient who has baseline hypertension, maybe that would shy you away from lenvatinib.
Sure. I think that's fair. In regards to the secondary endpoints of higher PFS, higher response rate, in the context of similar overall survival, it's hard to know what to do with that. Right. However, as practitioners, we tend to believe at times that maybe a higher response rate or higher PFS is important for patients who present with symptomatic disease, or patients who are ill enough where we're concerned whether they may make it to second or third line. So an agent that maybe gives us a bigger punch as far as response in front line may be favorable in such a setting. But this is really clinical practice. It's not hard scientific evidence.
It's not data driven.
Yes.